everyone. We are about to start this webinar today. Okay, good morning, good afternoon, and good evening, everyone. I am Shan, the International Hematology Marketing Manager of Wiradewi IVD. On behalf of Wiradewi, I would like to give you all a warm welcome to HemaTalk Episode 5 on infectious diseases today. It's about time to start our webinar. Please allow me to introduce our host, Dr. Ramon. Dr. Ramon is the Scientific Research and Medical Affairs of Wiradewi IVD, and he is also the Associate Professor of Artificial Intelligence at the University of Applied Sciences of Southern Switzerland. So please give a warm welcome to Dr. Ramon. Thank you.
Thank you. Thank you so much. Okay, it is my pleasure today to be here in the episode 5 of the HemaTalk from Wiradewi, and it's amazing because this topic is one of my preferences in hematology. For the reason I think we are going to enjoy it. We are very privileged to have very good speakers this time. Let me share one presentation I did to introduce the topic. Please, can you permit me to share? Okay, perfect.
Sure. I think you can share right now.
Okay. Let me introduce about hematological parameters and infections. For many years, only the classical parameters were developed in hematology. Neutrophils, percentage and absolute. There is a discussion if it's neutrophil in percentage has to be eliminated, but I have to remind that some infections have leukopenia. For example, Salmonella typhi infection. And in this case, if we use absolute, we will never detect this infection. But in general, absolute is preferred. Lymphocytes, of course, to make a differential diagnosis between viral and bacterial, neutrophil lymphocyte ratio, platelets, eosinophils, moreover when they are low, etc. Hematograms and bands. Here, I will not enter in this discussion here, but bands were used still now the pediatricians ask for bands to detect infections in children, but were used classically in hematology for many years, and reactive lymphocytes. But in the meantime, till 2005, biochemistry has developed a lot of parameters, interleukin-6, procalcitonin, etc., of course, CRP. But the thing is, hematology was like sleeping, not developing enough new parameters. Things have changed after 2005. Sorry. Yes. After 2005 were developed because people that have hematological instruments with scatter plots, they began to see that in many infections, the morphology of the scatter plots change. For example, in an infection, the neutrophil went up in the volume channel, and that was useful for sure. And everybody, we were using that for the validation or for the diagnosis of infectious disease. But of course, in 2005, we're beginning to be used the cell population data, that is the same changes that we observe in the morphology in the scatter plots measuring the volume, not only of the platelets and the neutrophils, but also the leukocytes. And were developed the first application about malaria that I did myself, using the monocyte volume and standard deviation of the volume and lymphocyte volume and standard deviation after many other parameters, neutrophil fluorescence, monocyte scatter, etc. IPF was also very important in the development of infections. Why? Because as Professor Gina Zini and Dr. Sabrina Boro said, they are higher 2 days before the sepsis. In the meantime, there is an infection. Of course, the ideal parameter is the ideal that predicts what is going to happen, and you can incorporate a new therapy before it occurs. Lately, we have now developed in the last months, in the last year, NLR, RDWSD, MPV, and monocyte Z. Monocyte Z is the monocyte volume, and I participated in this study. We can see here the morphology of the monocyte volume in a normal case, in the monocyte of the COVID infection before the cytokine storm, and the monocyte volume, the monocyte size in a severe case of COVID. And here we can see the evolution of these parameters in one patient day by day. We can see that in the phase 1 that the patient is still with no severe light infection of COVID. One day before the patients enter in the cytokine storm, the monocyte volume increase, and that permits also to predict not only IPF, monocyte volume, to predict that the patient is going to enter in the critic severe case and maybe in the future introduce therapy before it occurs. The same MPV. MPV and IPF are much related. IPF is much specific, but also appears in this study that increase one day before the cytokine storm. For this reason, now hematology is time for hematology, and now we are very lucky to have these honored speakers that will introduce us all these topics during this webinar. I am happy to introduce Dr. Antonio La Gioia from Italy. He's the laboratory medicine area manager for the SEMUS NGO in Livorno, Italy. He's director and referent teacher of diagnostic of hematology in the CBIO Permanent School of Laboratory Medicine. He's an emeritus director of clinical pathology and director of clinical chemistry and microbiology laboratory. He's a professional consultant in diagnostic hematology for the Medical Systems Company. He published over 40 articles in journals, including cancer, in lymphoma, myeloma, hematological studies in blast, morphology, platelets aggregation, body fluids. We are very honored to have Dr. La Gioia here in the meeting. Welcome, Dr. La Gioia. Buongiorno, e siamo felici di averlo con noi. Can you please introduce Dr.
Yes, okay.
Yeah.
Buongiorno, good morning. My name is Antonio La Gioia. I am the past director of the clinical laboratory in Leghorn, Italy, in the hospital from Leghorn until 2010, the year when I retired. I dealt with many tasks within the clinical laboratory, but I especially dealt with diagnostic hematology. That was my favorite topic. Even though I was lucky enough to work since the early 80s until today with the most important hematological analyzers that are available on the market. Since 2013, I have started cooperating with an Italian non-governmental organization, which is called SEMUS, whose mission is to improve lab medicine in developing countries. At present, the SEMUS is operating in the East Africa regions. It founded a very nice clinical laboratory in the Hargeisa, which is the main town of Somaliland, within a public pediatric hospital, and it is now starting a similar cooperative activity in the St. Francis Referral Hospital in the Tanzanian country. Let me talk about the morphological changes. Just a minute. I would like to talk about the morphological changes in the instrumental scattergrams, dealing with a few infectious diseases. And for this purpose, I will mainly use the additional information coming from cytogram rotation. Morphological changes that have been observed in the instrumental scattergrams are often caused by predictable results of relationships between the infective agent and defensive cells in peripheral blood. And that depends on variations in the leukocyte number and are non-specific in most cases, since they are also common to reactive situations and other infectious agents. 3D technology is based on the forward laser scatter signals, as well as on fluorescence signals, as well as backwards laser scatter, namely the three-dimension. The rotation function of the three-dimensional scattergrams resulting by the cellular analysis allows to evaluate variations in the cell cluster morphology that otherwise would have been hidden in the two-dimensional view. Let me now briefly describe three different scattergrams models with reference to 3D scattergrams, which can be of diagnostic help in the diagnostic field. First of all, the first model is the following: cytographic characteristics derive from cells deriving from native cells that are clustered in a significant way in the three-dimensional cytograms. In the second model, the cytographic abnormalities are due to infective agents in a peripheral blood and do not depend on cellular reactions during the progress of the infection. And there is a last situation is the specific case of malaria, where morphological abnormalities of scattergrams, diff scattergrams, do not derive from the presence of modified leukocytes or from parasites as such. And therefore, the analyzer can therefore analyze the resistant blood cells within the malaria parasites. As for malaria, I will just make a few hints because, as already well known, malaria in Italy is just present in very few imported cases. Therefore, I will just refer to cytographic abnormalities from a cytographic point of view, making reference to a few infections, as you can read here on this slide. In this diff scattergram, infected red blood cells that are resistant to lysis are grouped together with intermediate intensity between neutrophils and eosinophils. As for granulocytes, the neutrality to eosinophils or eosinophils can therefore lead to a pseudo neutrophilia situation or pseudo eosinophilia. And so the infected RBC, the red blood cells, couldn't be produced, and only morphology of scattergrams can be essential for the diagnosis and identification of imported malaria, as well as far as the Italian situation is concerned. Now, talking about the cases where I have direct experience, let's start with infectious mononucleosis that can be identified with the activated cells, the modified cells. In infectious mononucleosis, activated lymphocytes appear in the peripheral blood already during the first week of the infection. These cells, deriving from morphological and functional transformation of CD8 positive T lymphocytes, show an increased cytoplasmic content of RNA content that is necessary for the synthesization of more significant quantities of cytokines and other mediators of the immune response. The diff scattergram here is quite evocative in the early stages of the disease. The green cluster of lymphocytes extends along the FL axis of the increased nucleic acid content, showing an elongated drop shape. And immediately after their first appearance, activated lymphocytes start an involution process from a morphofunctional point of view and turn into apoptic cells. This cytogram rotation makes a second lymphocyte cluster visible with the smaller cells and reduced nucleic acid content as against activated and normal lymphocytes. In the non-rotated diff scattergram, the overlapping of the two clusters that I've just described causes a bend towards the right of the lower part of the drop-shaped cluster, giving rise to a typical unmistakable morphology. Scattergram 3D diff rotation allows, therefore, to identify the apoptotic cluster along the FL dimension, even though there is a reduced cellular content. And the cytographic aspect is almost pathognomonic of the acute phase of IM deriving from EB virus or a CM virus or other infectious diseases characterized by similar involvement of CD8 positive lymphocyte involvement, such as toxoplasmosis, rubella, acute viral hepatitis, and others. Based on our experience, the scattergram morphology experience that has been described so far is present only in this kind of infectious pathologies. Other typical lymphocytoses with different scattergram morphologies, such as follicular, mantle cell, or splenic lymphomas, never showed a similar morphology. Not even so, the lymphocyte cluster splitting, and the same holds true for the presence of blasts, either lymphoid or myeloid blasts, that can lead to a pseudo lymphocytic cluster, as you can see in the CC1 figure. The quantification of apoptotic cells by light microscopy is not generally requested due to some pre-analysis criticalities. Furthermore, it is believed that this data, namely the quantification of apoptotic cells, do not add any diagnostic or prognostic information as for the IM. We have anyway tried to quantify apoptotic cells using a research software that was provided by MindRay a few years ago. And then we compared these results with microscopic counts. The results of these quantification have shown a higher sensitivity and specificity from a diagnostic point of view as against the microscopy one. And therefore, This kind of software should be made available by MindRay for all customers of this gating software or quantification of apoptotic cells as a research parameter. Furthermore, the presence of cluster of apoptotic cells should be accompanied by a specific flag that could alert the microscopic review by those laboratories, because unfortunately there are too many laboratories that neglected the display of instrumental cytograms for the diagnosis purposes. The second situation that I wanted to share with you concerns sepsis, especially the one deriving from Candida that is present in peripheral blood that produces both direct and indirect modifications. Indirect modifications depend on the interactions between pathogens and leukocytes. Therefore, for my presentation, I will refer to these two not so recent references, but that are closer to the current state of the art. The first one is a case report concerning Candida parapsilosis, and another one. And as for the second one, we added Candida albicans standardized in terms of number of Cu per liter in normal blood specimens, samples, and then we use these blood samples at time 0, namely after the addition of suspension of Candida at standardized intervals of time. These two rotated diff scattergrams derive from the first case of diagnosis of Candida parapsilosis sepsis. These scattergrams clearly show a great complexity deriving from the simultaneous presence of many factors that are related to elements that can be found in the peripheral blood, as we will see later on. Rotation in every direction will therefore, at different angles, will therefore show that this complexity is caused by different factors, namely the presence of additional clusters, morphological change in normal clusters, and finally, the relevant overlapping between different clusters. Most changes are strictly related to the pathophysiological aspects and evolutions of sepsis. Candida sepsis generally starts from a colonization site that might be located, in most cases, in the site of a central venous catheter. And from there, the Candida sepsis actively multiplies in blood. In the stimulated in vitro sepsis, we obtained these results with the addition of Candida, with the presence of several free circulating blastospores that form a sort of blue carpet on the 3D cube floor. At the same time, we can observe in the NRBC cytogram, we can observe the presence of these yeasts that are enhanced by this fuchsia-colored cluster and can be counted as pseudo-erythroblasts. Many other blastospores circulate in an aggregate form in clusters, therefore causing the formation of a new additional cluster with lower complexity than neutrophils. Due to the contiguity with the neutrophil and lymphocyte clusters, that additional cellular population can be included in each of these randomly, result in a condition of pseudo-neutrophilia or pseudo-lymphocytosis, respectively. Starting from time zero, where free blastospores become clear clusters of pseudo-neutrophilia or pseudo-lymphocytosis, give rise to a set of events that lead to further morphological changes in these scattergrams at the same time. These three pictures that you can see here have been obtained after 5 minutes of the addition of Candida suspension to the blood. To the left, you can see a neutrophil that is ready to a phagocytic activity of a blastospore. 5 minutes afterwards, the neutrophil got close to the second blastospore and starts again the phagocytosis of this blastospore, and then 3 minutes later, the phagocytic activity is almost completed. This is what happens in vivo, both in simulated sepsis and in clinical sepsis. Now, let's have a look at how instrumental scattergrams read these changes. The morphology of scattergrams is modified already after 6 minutes from the addition. Neutrophils, including blastospores, as we could see in the previous image where there was the phagocytosis, increase in size and cause the extension of the cluster along the FS axis, along the size axis. At the same time, the phagocyted blastospores are not included in the count, and in this case at time zero are 4,155 per liter, and and there has been a reduction by 25%, 3,212 per liter, 60 minutes later, as against time zero. As for the in vitro neutrophilic phagocytic activity goes on, I'm sorry, my dogs, he's saying, are barking. After 3 hours, neutrophils have been full of Candida blastospores, as you can see in these two in vivo figures, and the ones that have been enhanced in blue, and they are filled in until they burst. The presence of so much nucleic acid with the increase of phagocyted blastospores allows the instrumental cell analysis system to consider these cells as immature granulocytes. Meanwhile, the phagocytic activity keeps on subtracting free yeast from the NRBC cluster, which is 1.611 per 10th to the 9th per liter, that had led to a much higher value of 4,155. At the same time, remember the blue carpet on the floor of the 3D cube became less dense and less extended. It reduced in size. The NRBC count, and I want to call your attention to this cytogram, the count of NRBC in the thanks to the BC Series 6000 instrument, therefore shows the free spores that can be seen in the scattergram, and this has showed the greatest specificity and sensitivity, as well as the best earliest diagnosis for sepsis. There you can see that the fuchsia cluster is due to the presence of a moderate quantity of erythroblasts that are circulating in the blood. This is abnormal. An NRBC scattergram with the erythroblasts circulating in the patient's blood. There you can see reduced quantity, 0.438 per 10th to the 9th per liter. And there you can see that if you draw a line starting from 0, the main axis of this cluster that is egg-shaped of erythroblasts is as 35 degrees angle in terms of its position. The second scattergram comes from a normal blood sample with the addition of the suspension of Candida, as already said, so that it causes a sort of pseudo NRBC content that is more or less equivalent to the clinical sample, 2.91% of white blood cells corresponding to 0.371 per 10 to the 9th per liter. What are the main differences of this cluster that can be clearly seen along this straight line that follows the main axis of neutrophil cluster with two specificities? It doesn't start from 0, but quite far away from 0, with an angle of about 50 degrees. And these characteristics between the two clusters, the true erythroblasts and the pseudo-erythroblasts, are fundamental for the diagnostic assessment of this case, of this situation. Well, the different spatial orientation of the fuchsia cluster is of great diagnostic significance, and it allows to maintain the diagnostic result for Candida sepsis, even when in samples show the presence of the real NRBC, as in the sample containing both true and pseudo NRBC, namely Candida blastospore, so that we can see that in this peripheral blood there are two abnormal situations, one deriving from true erythroblasts, and the other one, the presence of pseudo NRBC deriving from Candida blastospores. And in these situations, in the intensive care units, this is very important, as this article shows. The presence of nucleated red blood cells is associated to many diseases, but with a highly unfavorable prognosis. So the diagnostic relevance of erythroblasts is great, and therefore this is also, that is why it is important to have the addition of the candida as well. We also evaluated the minimum number of blastospores necessary for the NRBC cluster takes on its typical shape and layout. As the left figure shows, below 0.154 per 10 by 10 to the ninth per liter is not easy to let us understand whether it is true or pseudo NRBC. And these uncertainties disappear to a bit less than 100 blastospores per liter, and the 154 and the cluster showing these values can clearly be perceived as a non-NRBC, but as a candida-related cluster. Well, the point 154 value is very important because it has been seen that the microscopy for it to identify blastospores in the blood stain, blastospore dimension has to be 3 times greater, or mainly the analytical sensitivity due to the presence of a candida in peripheral time is 3 times greater from a cytographic point of view as against the microscopy observation. So we are almost at the pre-conclusion. So the 2 examples of Candida parapsilosis are the following: study with in vitro simulation of the sepsis deriving from Candida albicans led us to do the same methodology to analyze other types of infectious diseases. A few results can be anticipated. This is not published yet, at least as far as for the morphology of diff scattergrams at time 0, and for the evolution of pseudo NRBC cluster do not show any significant differences as against other types of Candida the parapsilosis in vivo, but the same result was obtained also with the Candida glabrata and Candida krusei. Differences were quite relevant as well among the various analyzers, because these samples with the addition of Candida suspension were assayed not just on PC 600 and 6800, on CMX XN, and on Abbott Sapphire. And results are quite interesting, but this is another story. And we will see whether we will carry out a further webinar to dwell on the details of these further results. To conclude, I would like to mention to refer to the famous guidelines called the so-called 41 rules that are usually widely used as guidelines for microscopic review. None of these rules provide decision-based for instrumental scattergrams, because scattergrams and the other 3D scattergrams and graphic scattergrams are generally regarded as a waste of time. Do not agree at all. Because after 40 years of direct experience led me to consider automated hematology as a diagnostic discipline, which is difficult but irreplaceable, that is equally important as the morphological kind of hematology. I do believe in the diagnostic value deriving from instrumental hematology using various types of analyzers. And if I've so far convinced a few colleagues of the importance and relevance of scattergrams, I'm very happy, but I know that I am old enough now. Don Quixote instrumental analyzers, and if a very important lesson that it is useless to fight against windmills. So my attitude and is not enough, and the refusal of instrumental scattergrams, unfortunately, may continue. So more realistically, I would like to suggest the Mindray to develop an algorithm based on positional data from the NRBC cytograms to produce a specific flag, such as, for example, suspected candidemia. In my view, it could be beneficial for critical patients whose non-cytographic diagnosis might lead to even fatal diagnostic delays. And these are my conclusions that are not strictly scientific. Laboratory medicine technologies of course are an opportunity for the discovering of improved diagnostic equipment. They have allowed us to understand things, new things, or to see things from a different point of view. They have stimulated our curiosity and sometimes our imagination. And last but not least, they have shown these technologies, lab medicine technologies have shown that they can therefore can help young people to grow and older people to stay young. Thank you. Thanks for your attention.
Thank you very much, Professor Antonio La Gioia. It was very useful, and I fully support your conclusions. Scatter plots are absolutely a must, and will avoid many reviews, smear reviews, will detect false eosinophilias, because it is absolutely a must. And I recommend always to print and collect the scatter plots and to put it in a poster in the place of the validation of the instruments to help the people to continue training using that. And really, but that was very good to make conscience to all the people about this topic. And thank you so much for this nice presentation. Now it's time for the next speaker. And now it's questions and answers. Sorry, that was good to use the presentation to really not forget that now is a question of the audience using the chat to ask any question to Dr. La Gioia. Any question? Let me see the chat. If we can read any question. Okay, let me comment something to you, Dr. La Joya. Really, it is now the way we are trying to do that, what you said, how we can capture the attention on special scatter plots. And that for that, we are using cell population data. Cell population data is just to give the mean volume, the mean fluorescence, the mean site scatter of each population, including an RBC. And that will help that when you have, for example, a high NRBC count, to see if is the average mean volume, mean flow site scatter, mean fluorescence. If it's not, will appear a flag, and maybe also big NRBCs or suspect of any parasite if we can collect cases. And that is an important point, because we ask all the audience to ask your service guy, when you have a very interesting case like Candida sepsis or any other leishmania, whatever, ask the service to save this case, to record this case with raw data. This case can be sent to the MinRay development, and there, collecting cases, we can develop and trying the algorithms to teach the software to recognize these cases. That is gold for MinRay research development. That is to have the cases with raw data, and of course the scatter plots will help us to understand, to show other customers, and that is really amazing. Dr. La Joya, can you give me your opinion about that?
Yes, the new parameter, in my opinion, are most important and increase the capability of hematological analyzer in discovering the infectious disease. But I needed to increase my message. In the laboratory, the cytographic images should observed continuously by the operator, because not only this modification can be translated in flags or other message from the analyzer. So the skilling in the cytographic observation is the most important tool in this difficult diagnosis tool.
Okay, there is a question from the audience. Compared to the biochemistry parameters, C-reactive protein, SAA, procalcitonin, IL-6, what is the sensitivity of the scattergram analysis?
I don't thank you for the question. I don't know direct experience about this. And we must to consider that this patient are suffering from numerous pathologies, and so this biochemistry can be modified in strong modified. So it's difficult to separate the pre-existing situation from the new situation derived from the sepsis. So I think the biochemistry could be important, but I still my opinion is to observe cytographic change on the analyzer.
Yeah, and I agree with you. Some of these parameters, in my experience too, they are not specific of a species. The scatter plot for me is specific. Malaria have different scatter plots than Candida. Candida have different scatter plots than Leishmania, and that can be, and even in malaria, the different types have different scatter plots. I think the scatter plots can add much more specificity to the biochemistry parameters. And by the way, when we do studies including neutrophils, neutrophil fluorescence, cell population data, scatter, we see that these parameters are independent of the CRP and procalcitonin, and they can be combined algorithms are measuring them. There is another question for you. The question is, can all candida infections can be detected? And maybe also I will add, can be better the automated analysis that count 8,000 cells than the microscopic analysis detecting candida?
Sorry, Ramon, can you shortly translate this question?
Si la infezione della candida può essere tutti possono essere identificata con il scatter plot.
In my thank you. In my experience, yes, the change of scatter plots are specific and very earlier during the infection. Another question is the possibility to start the therapy against the candida shortly with respect to the results from the culture. After a cytographic change, we can start this therapy and waiting for the culture is the most important information, in my opinion.
Yeah, very good point. And I can add also the follow-up. Once you initiate the treatment, you can see the decrease of the scatter plot population. That will help also to see if the treatment is working or not. And yes, and I fully agree with you. Perfect. Let me see if there is any other question. How long the candida can be detected in peripheral blood? It is earlier than blood culture.
Yes, thank you. When we observe describe the modification, generally we don't know the starting of the disease, and so I refer my experience in the experimental situation. The modification of the 3D and mainly of the NRBC cytogram starts immediately after the presence of candida in the peripheral blood, immediately. And after this, the cytograms change their morphology and stay for many hours. Regarding the possibility to diagnose the candida sepsis earlier than the blood culture, my opinion is yes, it's very early.
Okay, another question in the last, please. All the other questions you can refer it to MinRay, and they will forward to us. Can I use this information about an RBC scattergram helping diagnosis of other pathogens?
Only depend on the interaction between the pathogen and the normal cells in peripheral blood. Changing the structure or the function of each cellular type, we can hypothesize to have the similar change in the scatter plots. but only the direct experience can be, from direct experience we can answer this question.
Thank you so much, Dr. La Joya. It was a pleasure to have you with us. Thank you so much. I hope that we can meet again in another HemaTalk meeting. Thank you.
Thank you all people.
Okay, and now we go for the next speaker. That is Dr. Professor Luigi Tripaldi. He's a director of the UOC Clinical Biochemistry and Microbiology and Virology of Ospedali dei Colli Healthcare Company, director of the Microbiology and Virology of Ospedali dei Colli, director of Clinical Pathology of Cotugno Hospital, and from Italy. And welcome, Professor Tripaldi. It's an honor to have you with us.
Good morning, all of you. I would like to thank Man Ray and all my colleagues for the invitation. We will talk about predictivity of hematological parameters in the course of sepsis. Since the Consensus Conference Committee in 1992, sepsis was defined as a clinical syndrome characterized by an abnormal systemic inflammatory response, SIRS, triggered off by infectious process for the penetration of pathogenic germs into the organism. But we opt for the 2016 sepsis definition that is referred to as a life-threatening organ dysfunction due to an inappropriate host response to infection. There you can see the various steps that characterize sepsis. It starts with the SIRS, the abnormal inflammatory response, with clinical parameters as well as lab parameters that characterize it in terms of number of white blood cells, less than 12,000 or more than 4,000, increase of bands by 10%, and increase of PCO2. And then the second step is characterized by either the confirmation or a suspected infection. And then the third step is a severe sepsis that involves organ damage with hypotension, SBP more than 90, and lactate more than 4 moles. And then the fourth step is a septic shock involving severe organ damage with hypotension and lactate. Some notes about epidemiology. It affects about 20 to 30 million people around the world, with more than 5 million children worldwide dying from sepsis every year. You can read the data. 1.6 million cases of sepsis in the US every year. 258,000 Americans die every year from sepsis. And again, in the US, it can be said that in the US, sepsis is the third main cause of death after cancer and heart disease. In Europe, too, we have 400 cases of sepsis per 100,000 inhabitants. That leads to more deaths, 10 times more than heart attacks. 250,000 cases in Italy alone, and unfortunately 1 out of 4 patients do not survive, with more than 60,000 deaths per year in our country alone. Anyway, sepsis is related to an increasing health emergency, which is a multi-resistance and hospital infections to these germs that are highly antibiotic resistant, and this determines a high mortality rate related to the antibiotic resistance. So we've got about 700,000 cases in the world that show this multi-resistance to antibiotics. And it can be said that it therefore affects 7 hospital patients in Italy, and that can even get to up to 15% when it comes to intensive care units. Time factor is fundamental. Time is an important variable because we know that every delay, even one day only in a diagnosis, that can lead to a 2-time increase of deaths in sepsis patients. So diagnosis, early diagnosis is absolutely fundamental. And so the lab plays a fundamental role. We all know the various lab exams and parameters to be quick in the sepsis diagnosis as early as possible, starting from everything pro-calcitonin, which is a guide. We know that when there is a reduction by 50% of pro-calcitonin, it means that we are on the right track, that the treatment is working. And then Percepsin, new markers with as MR pro ADM, protein C reactive, that is much broader than the 2 previous ones. And then for etiological diagnosis, we've got hemoculture in as for circulation in the blood of these germs. But of course, we have other types of examinations that identify organ damage, liver damage, coagulation tests. And so we know that sepsis is therefore followed by this, and then the lactic acid. And then so the complete blood count and examination is very important. So automated hematology plays a very important role. That is a set of the main types of equipment, as you can see, Siemens and the others, and each one of them uses different types of technology. And we have therefore checked, and there are many studies that really highlight the importance of morphostructural parameters that can be of help in an early diagnosis of sepsis. These are the early research works that have highlighted the importance of these parameters in the sepsis diagnosis back in 2005 in neonatal sepsis is a clinical case difficult to be interpreted. There might be confusion between the newborn sepsis and respiratory disturbances because and then we refer to full blood studies on in 2013 referring to the mean cell volumes of neutrophils or monocytes that are promising markers of sepsis occurring in elderly patients, as well as many other research works that refer to the various parameters that allow us to diagnose sepsis as early as possible. These are the results of examinations made in our hospital, where we have compared positional parameters with another important parameter, which is the CD64 expression on neutrophils by flow cytometry, and sepsis diagnosis to be confirmed also with a molecular diagnosis assessment and with a traditional technique, namely blood culture, full blood culture, full blood count. This is a platform that wanted to analyze volume and scatter of the cells. As you can see the scattergrams, the scatter cytograms with the 3 main populations, lymphocytes, monocytes, and granulocytes. And there you can see the normal values concerning size, conductivity, and scatter of this technology that was used at the time, that is very important technology with the mean parameters, volume, scatter, and also variability of these dimensions to be calculated by standard deviation. And there you can read about the great differences of these parameters concerning the average scatter in a normal population and the size of neutrophils as against the parameters in sepsis patients. There is a big difference. And there you can see that the size in normal patients at around 140 on average, the volume of neutrophils, whereas in sepsis, this value gets to 163 as against 5, and the same for average scatter with a reduction in this case, thanks to this platform of average scatter as against the sepsis, as against, sorry, the normal population. These are the results deriving from studies on positional parameters and with CD64 on 100 normal subjects with compared with 30 subjects suffering from sepsis. So we calculated fluorescence of CD64 on 100 normal subjects, and this value was compared with the results obtained on 30 patients suffering from sepsis, and we highlight the specificity and sensitivity by means of these parameters, the ROC curves, and this parameter is absolutely fundamental for sepsis patients and also with reference to positional parameters. This is the diagram used by main platforms, especially the one we use for Mindray and Siemens. So you see the laser beam targets the cells, and there you have light that is scattered, and thanks to lenses and filters, it is then received at a small angle. And so there is a light scatter at 90-degree angle or a small angle scatter, and this dimension is related to the cell size, and the light scatter is related to the complexity, granularity of the cells in a cytoplasmatic point of view. And then there is another important aspect, which is fluorescence, that is related to maturity and activation of cells, as we can see better in the following slides. This is what happens. There you have nucleated cell count with the acid pH reagent, stabilization of basophils, fluorescence staining of the NRBCs, nucleic acid staining with specific surfactant reagent, and a fluorochrome that therefore determines the fluorescence of these cells, as this case shows. And there you can see to the left as a fluorescence cytogram as against scattergram, in addition to the three main cell classes, neutrophils, monocytes, and lymphocytes, eosinophils and basophils. We can see immature basophils that are highly identified as immature granulocyte, and then lymphocytes that are activated, and namely activated B lymphocytes turning into plasma cells that will lead to the evolution of antibodies. And there you can read the positional parameters related to scatter, fluorescence, and dimension, the size. As for the three cell populations, the positional parameters of normal subjects, these are the values that are identified. Not just that, not just these values that are calculated on the average channel of these cell populations, but we also have variability related to the fluorescence scatter and forward scatter. And we also have the measurement of the size of these cell populations. To the left, you can see the average values on the horizontal axis of monocyte, lymphocytes, and neutrophils, I mean on the vertical axis. And then we therefore evaluate the cellular complexity of these three cell populations. In the fluorescences against the lateral scatter, you can see the variability of these parameters. And there you can see that these parameters are very important that can help us in assessing coming up with an early diagnosis of sepsis, as we can see better now. Let's see what happens when you have reactivity of neutrophils with an increase of immature granulocytes, IGs, but no alterations on normal neutrophil population. To the left, you can see the immature granulocyte population. When faced with dysplasia, we will be faced with a reduction of side scatter because there is a reduction of internal complexity due to hypogranularity, and we have an increase of scatter on a neutrophil population. Now, let's focus on what happens in infections, in sepsis in particular, and there you can see a relevant increase of fluorescence of granulocytes with a complete fusion with the immature granulocyte population. You can see the buffer that is encompassed by the granulocyte population, and this variation is due to phagocytosis, production of cytokines, and then you have production of immature granulocyte, as I was saying before, and as well as an increase of the complexity of monocytes with the monocyte population that moves towards the x-axis because there is an increased scatter of greater complexity. So you can see that these parameters have been certified that can be monitored, that are reactive lymphocytes as for the activation of lymphocytes, and then AS lymphocytes that will lead to the production of antibodies, the plasmacytoid transformation. Then you have neutrophil granularity intensity, NEUTGI related to the complexity due to the side scatter in our neutrophil population, and then neutrophil reactivity intensity and EUT related to neutrophils. And this slide now shows the phenomenon better on the fluorescence as against a side scatter diagram. You can see the increase of intensity of fluorescence of the average value of fluorescence in this population, and there is an increase on the x-axis of the complexity and of the side scatter. Let's see what happens in sepsis. You can see that there is a relevant increase of reactivity intensity of neutrophil population 64.1, and an increase of the variability of fluorescence of neutrophils, an important value, 1,280, as well as an increase of the a relevant increase of the complexity of monocytes due to the increase of side scatter of lymphocytes. This is our experience that I would like to share with you, that assessed the usefulness of structural parameters such as markers of infection and sepsis. So we assessed these parameters on 102 healthy subjects and 51 patients with a sepsis or a bacterial infection. Diagnosis was carried out based on blood culture, procalcitonin, PCR, and other values. There was a retrospective evaluation of results of the hematocytometric parameters related. Further tests were carried out. Adrenomedulin dosage and HLA-DR performed in particular during the treatment and the monitoring of patients with a reduction of HDL. So parameters were studied, assessed in these two groups, namely the donor group and the patient group, by using the Kruskal-Wallis test to assess the statistical significance of parameters observed in these two groups, the donor population and the patients. And then we evaluated and studied the diagnostic accuracy of positional parameters, assessing them by means of ROC curves analysis compared to AUC values, namely the area under the curve, calculating, assessing sensitivity, specificity, negative predictive and positive predictive values of these positional parameters deriving from the ROC curves. There you can see that in healthy subjects, you had this 76 males and 26 females in the healthy population. And as for the patient population, we had 32 males and 19 females. As for the age, the median was 44 in the healthy male subjects and 1964 in and then 66 for patients. Patients would come from the ICUs, 20, infectious disease department 18, then the resuscitation as well as others. These are the various values of our parameters, lab parameters on our patients. We have 51 patients, and on all of them we calculated PCT, PCR, HLA-DR, ADM. In 48, we highlight a PCR, PC reactive, and then 18 HLDR, etc., as you could read on the slide. And this is the situation that has emerged from the blood culture in 51 patients, 44 positive blood cultures, 22 gram positive, 18 gram negative, and microbic forms, 9%, 18 cases from Staphylococcus, 5 cases from E. coli, 5 from Klebsiella, 4 Acinetobacter, and then 2 from Enterococci. This is the evaluation of sepsis patients concerning HLA-DR on monocytes with a reduction in patients of the expression of HLA. And this is the table of data of positional parameters. You can see the red parameters that have been highlighted. The reactive intensity has increased as against normal subject of 54.4 as against 47, and then the standard deviation of fluorescence, the flow variability, 700 as against 555 in normal patients, as well as complexity. These two can be used as a parameter in cell size, but it is also important to see the complexity of monocytes. As you can see, mono X, we've got the incremental values of complexity in the average scatter of granulocytes, neutrophils in patients as against a normal healthy patients. Hence, the 3 parameters that we believe have been decisive and useful to have an early diagnosis and predictivity of the sepsis syndrome. Well, neutrophils, reactive intensity, fluorescence parameters, and the complexity of scattergrams of monocytes. This is the ROC curve study with parameters of neutrophils intensity, variability, and complexity of monocytes. And by using these parameters as cutoffs, and we obtain the sensitivity and specificity of a great relevance. This is the fluorescence of neutrophils with a sensitivity of 86 and 91.6 as for VPP, negative predictive value the same, and the fluorescence predictivity, high specificity, a good level of sensitivity, high sensitivity as for negative positive predictivity, complexity as well of monocytes. And excellent results have been obtained, and this is what we obtained. This is the comparison with cytograms, the reactive intensity values in sepsis patients 77 as against normal values, which is at around 48.8. This is a negative outcome in this patient with the swinging, ranging values as for the various parameters, but we obtained positional parameter values that were constantly increasing with the greater value of positional parameters as against the typical markers predictive of a sepsis. This is a test of monocyte activation with the assessment of these alpha elements with 100% of production of this. This is the same subject that I showed you before the 14th day. We had a 60% that reduces down to 44.3 at the 14th day. As for MindRay platform that performed very well as for sepsis, they use this SF cube, a 3D cube, where you have the three main parameters forward, side scatter, and fluorescence on the three axes of this 3D cube. These are the positional parameters of donor population analyzed with the MindRay platform. And so these parameters have been studied based on the MindRay platform. And this is the comparison with the sepsis patients as against the average donor patients. So there is a big difference of positional parameters between the donor population and the sepsis population. And this difference is even more significant than the one detected with another platform. So you can see the complexity, cellular complexity that is increased in sepsis patients, 427 as against 356, and the same for an EUY of 492, as well as all the other parameters. So big differences, relevant differences in these parameters that have been detected thanks to this platform in these two populations, the donor population and the sepsis population. This is a statistical comparison that compares what we observed, a big difference of the complexity of neutrophils between making a comparison between the donor population and sepsis population. So a statistical relevance of fluorescence of neutrophils in sepsis patients as against the normal subject, and the same for monocyte complexity concerning the dimension of monocytes in the population. And we also studied and assessed these positional parameters in subjects with COVID-19. Being in an infective disease hospital ward, positional parameters are assessed also with reference to COVID-19 patients. Thanks to the MindRay platform, we studied these COVID patients. This is a famous 3D cube that is used by the MindRay platform. And there you can see the study of these parameters. 314 COVID patients is against 165 healthy donors. And you can see the age, 23 to 92 years of age as for COVID patients, and between 19 and 65 years of age for the donors, males and females are subdivided according to the percentages that you could read on the slide. We didn't just study these parameters for COVID-19 as against the healthy population, but we also made a comparison with the previous sepsis patients. So we did this comparison as well as for sepsis. There you can see the age brackets of the populations that have been studied: 44 healthy subjects, 66 sepsis subjects, and then COVID-19, 63 years of age. And that is the percentage of males and females as for the populations being assessed and compared. As for fluorescence parameters of lymphocytes, we detected a higher value in SARS-CoV-2 patients as against healthy subjects and also as against sepsis subjects. As the same for we observed an increase as against the normal healthy subjects of fluorescence of subjects with COVID-19. And it goes without saying that the value is lower in the neutrophil parameters of patients with sepsis. The value is higher for sepsis patients. Again, the monocyte fluorescence in monocytes is higher, not just as against the healthy population, but also as against subjects in sepsis. So the relevance of these parameters, positional parameters, holds true in the assessment of patients affected by COVID-19. This is the final summary table with a close correlation between it is a statistically significant correlation of these parameters that have been assessed and detected. One asterisk, the normal population as against the COVID-19 population, and then the column with two asterisks where you have the statistical correlation related to sepsis patients, so COV-2 patients and sepsis patients. So relevant advantages have been obtained in positional parameters thanks to these platforms. As for the full blood test, especially with the MindRay platform, hence the importance of these new technologies that do highlight fluorescence in our cell populations that are totally related to activation and function of cells when we are faced with a sepsis. These parameters are easily detectable and highlightable in a very easy way, because you just need to run complete blood cell and you do an early diagnosis even before the sepsis has been diagnosed. So you have to be careful because these are technology dependent, and this data cannot be transferred from one platform to another one. So these technologies have to be deepened as far as each technological platform is concerned. The pre-analytical phase is important because data has to be assessed within 4 hours since the blood test, the sample. Otherwise, there are structural conditions that change and affect the positional parameters. And so temperature has to be assessed also based on our direct experience within our local lab. A few parameters are now certifiable and are CEIVD certified, but they should also be verified further. At this point, I would like to thank you for your attention.
Thank you very much, Professor Luigi Tripaldi, for your beautiful and very scientific presentation about this topic, the infections and hematological parameters. I have to point that your positional parameters are what is also called cell population data for other people that use this terminology, and really was great because for me, this is a new world in hematology. We have some questions for you, and let me see the chat. One of the questions is any difference between the cell population data positional parameters between viral infections and bacterial infections and sepsis?
Hi, nice to meet you. I'm the translator of Dr. Tripaldi. I'm gonna make the question and then I will translate the answer, okay?
Good. Yeah, the question if is any difference between cell population data positional parameters between viral and bacterial infection.
Differenza dei parametri posizionali nel monitoraggio dell'infezione sepsi batterico.
I parametri per la sepsi si muovono in ogni caso allo stesso modo, perché la sepsi proprio per definizione determina una reattività legata alla cascata delle citochine. Sicuramente vi sono differenze diciamo rispetto ad una sepsi di natura sicuramente batterica. Il nostro studio comunque è stato fatto su tutte sepsi di origine, quindi ad eziologia batterica.
Okay, he said that it showed that even in bacterial and viral sepsis we have difference about positional parameters, but our experience, our studies based on monitoring of bacterial. So we saw that in bacterial we have increase of that, but we are sure that also in viral is the same.
Yes, I agree with that. In the experience I have, yes, lymphocytes have a high standard deviation of the volume, of the size. That will be good. But yes, I agree with you. Sepsis has the reactivity, and now it's very important for the COVID. The cytokines, they activate the monocytes. The monocytes are different, and that is very important to predict sepsis. Okay, let me see if there's any other question. Okay. COVID patients show activated lymphocytes in numerous cases. Cytilgraphic changes. Ok, I don't know what is cytilgraphic, maybe a scatter plot. In pazienti di Covid si mostrano i linfociti attivati o reattivi se hai un cambio nel scatter plot in paziente di Covid.
Ok, nell'infezione da Covid-19 è interessante vedere che pur avendo un numero ridotto di linfociti è evidenziabile una popolazione di linfociti attivati, quindi avremo questi linfociti in attivazione plasmocitoide e allo stesso tempo però abbiamo anche una reattività sui granulociti. Quindi il citogramma è molto caratteristico del Covid, quindi è significativo del Covid perché abbiamo un'attivazione da un lato della serie linfocitaria e d'altro canto anche dei nostri granulociti.
Okay, he said that in the COVID patients we have two big differences. The first difference is about the lymphocyte because in COVID patients the lymphocytes are activated, so we can see this activated lymphocyte on the top of the scattergrams. And the second time is that when we see the immature granulocyte that are going up in the same, and we can see in two different colors from the normal nephropathy. So we have both of these two big differences in COVID patients.
And do you think, Professor Tripaldi, that can be due to we know that looking for the CD4 lymphocytes and NK cells in the severe cases after 8 days decrease dramatically near zero values, that can be over-infection of bacteries after the COVID infection?
But I have to translate the question.
se lei pensa che nel Covid, che vediamo che i linfociti CD4 e NK passano vicino a zero dopo 8 giorni, può avere una sovrainfezione batteriana in sopra dell'infezione del Covid, e questo spiegaria perché i neutrofili aumentano e anche hanno più reattività?
No, it said in the beginning that neutrophil increase because of the cytokine. So you have another infection that is correlated to the increase of the neutrophil, let's say. So it's not correlated to another infection that is bacterial. Can be, but it's not is the point.
Okay, but Dr. Atripaldi, Professor Atripaldi said, as you all have heard, is that this increase of neutrophils and monocytes will be for the cytokine storm that is very, very dangerous for this patient, not necessarily for a bacterial infection. Very good. Let me see if there's any other. How often do you recommend monitoring hematological positional parameters in patients with sepsis and COVID?
Quanto spesso tu raccomandi un monitoraggio ematologico dei parametri posizionali positivi?
Io lo raccomando molto spesso, in particolare ai medici del pronto soccorso, perché i parametri posizionali possono dare immediatamente un orientamento al clinico che si trova di fronte a un paziente febbrile che arriva al pronto soccorso e dargli un orientamento sulla diagnosi della sepsi, che poi viene confermata con altri esami e con altro studio.
Okay, well, here you say that you recommend very often this, especially to emergency doctor, just because this detection is early detection. So we can have early detection before that patient is going to other doctor or other test. After this, you can make this doctor to going to other test and verify if he's sepsis or not.
Okay, yes, yeah, I agree with that, and thank you for these answers. Any other question? Let me see the audience. No, that's all. Io devo dire che grazie. I have to say thank you so much, Professor Tripaldi, and the person that is helping you to translate. It's fantastic, and I hope that you will continue working with these positional parameters, cell population data, because for me it's the future of hematology in infections.
Thank you.
Thank you.
Thank you, Professor Tripaldi. Any other question, please forward to your MinRay representative. We will forward to the doctors to answer your questions. And now let's share my screen. Yes, now we have the honor to present another guest speaker from Indonesia. She is Professor Wiradewi Lestari from Bali. She is from the Department of Clinical Pathology from the Udayana University, Sangla Hospital, Denpasar, Bali. He's also working in his talk will burst about the utility of C-reactive protein and hematological parameters in the detection of sepsis. Thank you so much. You can yeah, I stop sharing my screen, please.
Okay, can you see our presentation?
You can put it in the show mode, please.
Show mode.
Yes, it's an it's like a triangle. It is a PDF or a PowerPoint?
Yeah. Wait. Wait. Okay.
Now it's perfect.
Okay. Good morning or good afternoon to all of participant or audience. Now I will start my presentation about utility of C-reactive protein or CRP and hematological parameters in the detection of sepsis. Okay. I can. Sorry. Okay. Sepsis. Sorry.
You can use the arrows in the bottom right of your keyboard to move. There are some arrows in your keyboard, or page down, page.
Yeah. Okay. Sepsis is a complex clinical syndrome that can complicate severe infection and is characterized by systemic inflammation and widespread organ dysfunction. Septic markers complement the result of the evaluation of clinical signs and risk factors in the diagnosis of sepsis. However, currently we don't have any available tests that are capable of providing perfect diagnostic accuracy. So false negative and false positive can occur. Sorry.
Use the page up, page down.
Yeah, I try but not work. Okay. Many biomarkers have been studied in helping to establish the diagnosis of sepsis, such as C-reactive protein or CRP and hematology parameters. The sensitivity of CRP as a biomarker of sepsis was 68 until 92%, and specificity is 40 until 67%. And hematology changes occur in almost every patient with severe sepsis. Oh, sorry. That means no. Okay. Sorry. Okay, this is the picture of the roles of innate and adaptive immune system in sepsis pathophysiology. In response to infunding pathogens, macrophages serve as the first line of defense, inducing the innate immune response, and pro-inflammatory cytokines such as TNF-alpha, interleukin-1 beta, and interleukin-6 as released from macrophage further augment systemic inflammation and epithelial barriers dysfunction. Whereas the anti-inflammatory cytokines such as interleukin-10 and TGF-beta counterbalance excessive immune response. And bacterial pathogens and systemic inflammatory mediators also promote epithelial barriers disruption to aggregate inflammation and induce the expression of ICAM1. The immature dendritic cell transform into it mature from upon interacting with the pathogen and serve as a professional antigen presenting cells. to activate the adaptive immune system by promoting T cell function through antigen presentation. And macrophage can also act as antigen presenting cells to enhance, process, and present pathogens to T cell and promote their activation and differentiation. And dendritic cells can also be activated by pathogens to trigger innate immune by producing pro and anti-inflammatory cytokine. And in sepsis, immune cells undergo apoptosis, leading to an immunosuppressive environment. I'm sorry, okay. CRP is part of the acute phase response, a physiological and metabolic reaction to an acute tissue injury of the different etiologies such as trauma, surgery, infection, and acute inflammation, which aim to neutralize the inflammatory agent and to promote the healing of the injured tissue. And after a trauma or the invasion of microorganism, an acute inflammatory reaction is initiated by activation of local resident cells, which promote the recruitment and activation of further inflammatory cells, including fibroblasts, leukocytes, and endothelial cells, and release pro-inflammatory cytokine, including interleukin-1, TNF-alpha, and interleukin-6. And the cytokines induce the production of proteins of the acute phase response in the liver, such as complement system, coagulation factors, protease inhibitors, metal binding protein, and CRP. And the production of CRP in the hepatocyte is mainly induced by interleukin-6, but can be further increased by synergy with interleukin-1. And during the acute phase response, CRP's hepatic synthesis rate increases within hours and can reach 1,000-fold levels, and level remain high as long as the inflammation or tissue damage persists and then decrease rapidly. Okay, the prototypical ligand of CRP is PC, which is present on some bacterial cells and damaged cells membrane, and CRP binding activated complement and opsonize them to phagocytosis. It also binds to FcGR1 and FcGR2 on the surface of leukocyte. FcGR1 and FcGR2A are stimulatory receptors, and cross-linking activates them and increasing phagocytosis and release of inflammatory cytokines. But FcGR2B is an inhibitory receptor, and cross-linking of it blocks activating signal. Okay. Okay, in this slide, we can see the sensitivity of CRP in 8 research with neonate subject with different cutoff, more than 8 or more than 10 or more than 15. The sensitivity of CRP are 28 until 69, but the specificity is high, more than 90%. But when CRP combined with the other markers such as procalcitonin, interleukin 8, interleukin 6, the sensitivity is higher, but the specificity is lower. Okay, in this slide, we can see the significant difference level of CRP in healthy volunteers, controls, acute myocardial infarction patient, and SIRS and sepsis. In healthy volunteer patient, the CRP concentration were 0.21, which were lower than those of the other groups. And the CRP concentration were higher in the sepsis groups, 18.9, than in non-infectious SIRS group, that was 1.7 milligram per deciliter. And the best cutoff value for CRP for predicting sepsis in the first 24 hours of SARS was 8 milligram per deciliter, with the sensitivity is 94.3% and specificity is 87.3%. Okay, in this slide, we can see the decrease in the mean percentage, or the percentage drop of mean from day 1 until day 5 of CRP was 55% in the living group, the blue colors, yeah. And there was an increase of percentage CRP in the expired or non-survival group, the red colors. And the decrease in the mean percentage of white blood cell was 27% in the living group, and there was an increase of percentage in the non-survival group. The percentage drop of mean CRP in a living group was higher compared to the other variables, such as respiratory rate, white blood cell, and SOFA score. And the other picture, we can see during the first 5 ICU days, we observe the means of CRP for survival patient are lower than non-survival patient. Okay, in this slide, we can see the change of hematological parameters in sepsis, such as increased number of white blood cell, there was anemia, thrombocytosis or thrombocytopenia, coagulation activation such as thrombin generation, fibrin formation, pro-inflammatory, and platelet activation. But some parameters are rarely available, and this situation is different in every country or every hospital. And this research showing that with all patients admitted in ICU, showing the increased number of leukocyte, neutrophil, and increased level of CRP, but decreased number of lymphocyte. And in this research showing the increased number of and percentage of neutrophil and decreased number and percentage of lymphocyte. And I will about in our hospital, we took 13 cases of sepsis patient at Sangla Hospital, and we look at the result of CRP and its hematological parameters. Not all of patients would test for CRP, and most patients are test for procalcitonin, because in our hospital we usually test the patient, the procalcitonin for patients suspected for sepsis. And we divided into 2 groups, adults and neonates group. And in the neonates group, 5 of 8 patients were tested for CRP, and one of them showed high result of CRP 122.04, and 5 of 8 patients were tested for procalcitonin, and 4 of them showed high result of procalcitonin. Yeah, you can see the red color is higher than the normal limit, and the blue color is lower than normal limit. In patients with high level of CRP and or procalcitonin, it was found agreement with the previous studies that there was an increase in the number and percentage of neutrophils and a decrease in the number and percentage of lymphocytes. And in these categories, we found a low or normal white blood cell and low or normal hemoglobin level and low or normal platelet count. And for adults categories, 4 of 5 patients were tested for CRP, and all of them saw high result of CRP, and all patients were tested for procalcitonin with high result of procalcitonin. In patients with high level of CRP and or procalcitonin, it was found agreement with the previous studies that there was an increase in the number and percentage of neutrophils and decrease in the number of and percentage of lymphocytes. In this category, we found low hemoglobin level and low or normal platelet count. We have not used the extended parameter for hemoglobin and for white blood cell in our hospital to detect sign of sepsis. And for conclusion, the CRP parameter is known to have several different types of cutoff between study, and both in
Professor Wiradewi, we cannot hear you. Professor Wiradewi. We cannot hear you.
Professor, please unmute your mic.
Okay, it's finished. Professor Wiradewi?
I think she mute her mic. Maybe let's see if there is any questions first.
Yep. Okay. Let's see if there's any question for her. No, I cannot see any question. Okay, let's make some comments about his presentation. Yeah, the different cutoffs. There are different cutoffs for different in the different studies. But I think it is important sometimes to review the cutoffs that are published in the literature with a short number of cases before to use it clinically in the hospital, that you are measuring the CRP, because we observed that the cutoffs are different from hospital to hospital. Another important point is to combine CRP with a scoring system or even with a formula. We remember to use the neutrophil volume or the monocyte anisocytosis, combine it with CRP summatory, or you can do a logistic regression, because that improves a lot the effectivity of CRP, combining with hematological parameters. The statisticians in your labs will help you to do that if you are not expert on that. And yet now it's, let me see if there's any other question for Professor Wiradewi. No. In this case, we finished the, let me share my screen. Wait a second. Let me make as a summary. Scatter plots can be very useful for the detection and follow-up of infections as malaria, sepsis caused by Candida. To review the scatter plots of cases with infections, it is very highly recommended. And positional parameters cell population data can be very accurate predicting or assessing sepsis. I was impressed with the data of Professor Atripaldi with a ROC curves of 0.960 for monocyte X, monocyte complexity, for monocyte for neutrophil Y, for 0.0907, 0.926. These ROC curves are amazing, much better sometimes than many studies using biochemistry parameters. And the goodness is these parameters can be combined with the biochemistry parameters. For this reason, thank you for this beautiful data. And now I have to thank you, all of you, for the attendance to this meeting. We achieved the number till 462 people attending this meeting. That is a record for that, and we hope to continue with these efforts. Professor Wiradewi, I know that you are here now. Can you hear me?
Yeah, I'm here now. Sorry.
Don't worry. Let me see if it's any question for you. Let's see. Let's see if it's any question. No. Okay. In this case, we continue. Please, we are very. We will be very happy if that you scan this QR code with your cell phone and you answer the survey. The survey will be very useful for us to continue improving our talks and our webinars, and to be like the Japanese say, Kaizen, every continuous improvement, every day better than the day before. Okay. Thank you so much for your attendance. It was very nice to be with you. I leave you with this QR till all of you have activate your cell phone and answer the survey. Okay. Thank you. Have a nice evening in the Far East. A good afternoon in Europe. Thank you so much.
Thank you, Dr. Ramon. I think I will check the screen because I will leave it for 20 minutes. Okay.
Okay.
Thank you
good.
so much.
Thank you, Dr. Ramon.
Thank you, Professor.
Thank you.
Professor
Sorry for the last slide.
Thank you. It's all right.
Automatically. I don't know why.
Thank
no,
you.
it's okay. Thank you so much.
Thank you. See you.
Bye-bye.
Bye-bye.